how I meet the challenges of heart failure management. Actually, the presentation after very attractive speech of Ashok Sheth, it is really a challenge for me to present the heart failure in such gathering. So, every stage of heart failure, all of you know that heart failure is the terminal stage and final pathway for all cardiac ailment, including the commonly prevalent coronary artery disease. So, the disease which starts after facing lot of challenge. So, disease itself is challenging to the cardiologist to manage it, to make the diagnosis, because the diagnosis of the heart failure is made by the clinical presentation, echocardiographic finding, and some peptides elevation documentation. These three makes the diagnosis of heart failure. But sometimes the diagnosis of the heart failure is so challenging that even after doing everything and our maximum effort, we cannot reach the diagnosis of heart failure. Especially in patients with heart failure with preserved ejection fraction, and when heart failure is associated with certain comorbidities like chronic kidney disease, it is really challenge to meet such diagnosis. So before going to my case presentation, I am going to present some literature, what the globe community thinks about the challenges of heart failure management. This is the presentation, that is the review article in the title of Current Challenges in the Management of the Heart Failure. As I have shortage of time, I am not going to discuss detailed in all the literatures. Another literature is the advances and challenges in the diagnosis and management of the heart failure. If you look to another diagnosis, there are a lot of barriers that we have to cross to reach the diagnosis and manage the patient. And there are some changes in the management of the heart failure. If you go back before 2021, the management is changed after 2021. So the management of the heart failure is changing. What we are thinking today will be obsolete tomorrow. So these changes of heart failure management is also a challenge. There are a lot of guidelines in the globe. We follow the ESC guideline, ACC ASA guideline, NICE guideline, and so on. But how far we can implement the treatment of the guideline-directed treatment of heart failure, that is also a challenge. And this article represents the challenges and strategies for the implementation of the guideline-directed medical therapy in heart failure patient. As it is a very important article, I will focus only 2 or 3 points on it. Why it is challenging? What are the challenges? The challenges is some factor, that is the most important factor, is the patient-related factor that includes the comorbidities along with heart failure, advanced age of the patient, frailty, cognitive impairment of the patients, poor adherence to the therapy, and overall the socio-economic status. All of you know the treatment of the heart failure is really expensive issue. And another issue is the treatment-related factors, that is the intolerance to the therapy of the heart failure or side effects of the drug that is used in heart failure. And another is the healthcare-related factors, that is the availability and accessibility of the heart failure care. And another important issue is the international disparity in the resource of the heart failure management. That is also important, especially the country like, developing country like ours. If you look at the Asian and ESC long-term registry for the management of the heart failure, you will find that recommended dose is attained in Asian population is very low. Even in European population, where the heart failure treatment was prescribed to the standard protocol, but less than 1/3 of the patient received the target dose of therapies of heart failure. Another challenge is the management of some other comorbidities like obesity, and some people documented certain groups of challenge like top 10 challenges, 20 challenges like this. And heart failure home management, basically we cannot treat the patient in the hospital the whole life. So we have to treat the patient in the home. And this home management itself is a challenge, and it causes the repeated hospitalization of the patient. And the challenges and management option of hyperkalemia in heart failure, especially when it is associated with chronic kidney disease, it is a real challenge to manage this group of patients. And heart failure diagnosis, management, and primary care, secondary care, burden and challenges of the heart failure in patients with chronic kidney diseases. Beyond that, there is also challenges in the economy. Economy is the vital role, plays vital role in the management of the heart failure. And next is the policy. How we can make the policy, because the single policy cannot serve the whole globe. So we have to segment policy in the globe according to the socio-economic status of that group of population. So keeping all these challenges in mind, just I am presenting a case that will be in some part of the challenge. That is the 67 years gentleman visited me with the diagnosis of hypertension, diabetes, end-stage renal disease, on maintenance hemodialysis. He is doing twice dialysis in a week, and cardiomyopathy. It is not established. It is ischemic or non-ischemic, and heart failure with reduced ejection fraction. And his presenting symptom was shortness of breath, occasional PND, leg swelling, anorexia, and important symptom is that when he goes for the dialysis, his blood pressure drops, and that compels the patient to hold the medicine or antihypertensive medicine at the morning on the day of dialysis. With this challenge, the patient presented to me. So if you look at the presentation of the patient, what are the challenges here? There are dual burden. One burden is the CKD, another burden is the chronic congestive heart failure. So in such situation, there is unacceptably high rates of symptom load, repeated hospitalization, and higher mortality. So if we look at a patient of heart failure, to half to two-thirds of the patient, if we estimate the GFR found below 60. And US renal data system in 2016, they documented the prevalence of heart failure in CKD patient is approximately 26%, which drops to 6% only when there is no CKD. So CKD definitely increases the incidence of heart failure. And another estimated 44% patient develop ESRD in heart failure, and distribution like that. As the time is short, I am going to make it short. So de novo heart failure in general population is less than, incidence is less than 1%. But in CKD group of patients, it is 17 to 21%. And post-transplant de novo heart failure develops in about 18% over 3 years. And the risk of the developing heart failure is the atherosclerotic as well as the non-atherosclerotic like the left ventricular hypertrophy that is independent of other factors that develops in kidney failure. So, what is the impact of heart failure in renal function? One is the hemodynamic impact, all of you know, by hypotension, renal perfusion, congestion, etc. But the failing heart releases cardiokinins in excess that has got the impact in peripheral organ, including kidney. And this cardiotrophin, one of the interleukin-6 family that is produced and secreted in excess in failing heart, that induces renal fibrosis and renal dysfunction, ultimately that progresses to heart failure. Venous congestion is more important than the renal flow reduction, but the main driving force is some agent, inflammatory agent and neurohormonal agent that produces deterioration of the kidney function in heart failure patient. An economic impact when this kind of patient of chronic kidney disease and heart failure comes, the economic burden increases by 93, that is documented in 2017. That is when two diseases combined, the expense is doubled. So in this diagram, in first panel, you can see that is the linear relationship of.
Thank you, Professor Abdul Kader Akanda, sir, for your excellent speech. But due to time shortage, we are not able.
Probably I can get 5 minutes for the discussion.
Sir, actually,
I have
yes, sir.
missed my time.
Yes, sir. But we have to cut short with the question answer portion, sir, because of the shortage of time. Sorry, sir. So now we are going to call upon stage our third speaker, Dr. Chayan Singha, and his topic will be on fighters always back.
Honorable Chairperson, respected discussion, dear moderators and learned audience, very good noon, and welcome to everybody on today's session. Today I would like to just going to present cases, and the title is Fighters Are Always Back. Yeah, it is possible if the timely appropriate measures are taken. The journey of my patient began in the mid of the 2021 when the COVID was in peak. A 65 years old diabetic lady, she got admitted into a hospital with severe COVID-19. Despite of all her therapeutics, her condition was not improved. So ejection fraction was noted 45%. NT-proBNP was normal. She was on fantastic 4 anti-failure drug. And she was evaluated for her hemoptysis, and CT was done. Bilateral thick wall cavitating lesion. So we suspect this may be case of lung abscess or fungal infection. So initially she was on, I discussed with him regarding the treatment, and she, according to his advice, she was liposomal amphotericin B and posaconazole. And eventually her condition was improved and she settled to near normal life, and his ejection fraction was settled within 3 months. But again, but she was reluctant, and 1 year later she developed cough, left-sided pulmonary chest pain, high-grade fever, and she was evaluated by local physician, followed by she admitted into a tertiary hospital where she revealed a case of encysted pyothorax. So intercostal tube DNS was given. Her condition was not satisfactorily improved, and little bit she went septic shock with multiple dysfunction. So she was along with the other investigation, echo was done. Again showed the echo was, LV was usually dilated and global hypokinesia. LV function was severely reduced, NB and RV function. And her condition was gradually changed. She was 4 anti-failure drug with extensive counseling regarding her lifestyle
and he will be talking on the topics of HEPREF in young adults with dilated cardiomyopathy, the best clinical practice.
Assalamu alaikum and good afternoon, Honorable Chairperson, respected discussant, Honorable teachers and colleagues. Well, I'll be today talking about heart failure with reserved ejection fraction in was around 25% with severe MTR. NT-proBNP was raised. Diagnosis maybe is a dilated cardiomyopathy. Next case. It's a 28-year-old patient who came with shortness of breath and history of prolonged substance abuse. And his EC shows T inversion in V1 to V6 with QTC prolongation, and he has global hypokinesia, dilated LV, EF is around 30%, changes, and CG was normal, NT-proBNP was raised. My third case, after inquiry, we found out that the patient had episode of COVID 4 weeks back. And ECG shows 1 to 2 millimeter of ST changes in lead 1 AVL and ST elevation depression AVR, whereas there was J-point elevation in lead 2, 3 and AVF and TF inversion. And echo shows regional motion abnormality, mildly dilated LV, which was around 55%, mild MR, and severe, and including anti-proBNP, which was around 13 and 70%. These all three cases may be divergent in presentation, may be diverse etiological, all have the same common diagnosis, dilated cardiomyopathy. So regarding these issues, one of the most important tools that we have in our hand, apart from echocardiography, CMR, cardiac magnetic resonance, is one of the important tools that is less used in our country. So echocardiographic criteria, which is prescribed or considered for diagnosis of dilated cardiomyopathy, include left ventricular end diastolic diameter, which is more than 117% of the age and body systolic dysfunction, which is marked by reduction of ejection fraction below 40% and fractional shortening of 25%. In majority of patients, the dilated cardiomyopathy involves inflammatory process and genetical hallmarks go through the clinical progression of dilated cardiomyopathy. Dilated cardiomyopathy may have mild subclinical phase and a clinical phase. In subclinical phase, there may be no changes, maybe minor hypokinesia, maybe dilation of cardiac chambers. But in progressive disease phase, it may be classified in two parts. One is hypokinesia in non-dilated cardiomyopathy and dilated proper, where in non-dilated part, there may be global hypokinesia, but heart may not be dilated in the initial phase. But later on, if treatment is not initiated, it may dilate. But in dilated cardiomyopathy, all the fundamental features will be present. So regarding the issue, what may the treatment do the patient with dilated cardiomyopathy? You know, in a LV, normal LV, in dilated cardiomyopathy, heart failure, there may be dilatation and reduction of ejection fraction. Through medical therapy and devices, there may be full recovery. That is, EF may be normal or near normal, above 50%. There may be partial recovery, or there will be no functional changes of ejection fraction. So, looking at the background of these changes, there should be a targeted approach of therapies towards the improvement of the patient of dilated cardiomyopathy. And the main role is to remove or reduce the myocardial susceptibility and myocardial workload. For reducing and myocardial workload, we have to initiate some drug that is useful in reducing the workload of the heart, that is beta blocker. Apart from that, we have to reduce the susceptibility of myocardial dysfunction, which includes the different diseases and toxins and genetic predisposition, in which case SGLT2 receptor inhibitors are a great drug of choice. So after reducing the myocardial susceptibility and myocardial workload, the balance in between these two will give us the remission or relapse. So for prevention or remission of the patient, you have to continue using these drugs. And if you withdraw the drugs, maybe remission will not stay as we intend. So ESC guideline in 2021 has given us the choice of drugs, the fundamental drugs that we should be using in treating a patient with dilated cardiomyopathy, especially not dilated cardiomyopathy, as a whole patient with heart failure with reduced ejection fraction. In the class of drugs, all drugs are mentioned, but Secrebutyl by Arnie was placed as one big classification. But later on, it was changed. Apart from these 4 drugs, other drugs of choice are loop diuretics and ARB whenever is needed. From ESC guideline, SEC had little bit changed. They have placed Arnie in the top of the list, and other 3 drugs are as it is used as before. Apart from that, SEC have said that in patients with heart failure reduced ejection fraction, titration of guideline-directed medicines, dosing to achieve a target dose should be efficacious and RCTs. That means it should reduce cardiovascular mortality and to reduce the heart failure hospitalization. Unless not well tolerated, all drugs should be used regularly. As a whole, the heart failure management with reduced ejection looks like this. We know we have to use the fundamental 4 drugs along with diuretics, and if needed, according to the cost, other drugs should be used, or the other procedure like ICD or CRT should be employed. So, what is the sequence and up titration of GMD? Use of all drugs classes has been estimated to reduce the all-cause mortality by 74%. There are some sequence of uses that has been advised. Initially, one by Packer and McMurray, beta blocker and SGLT2 should be in the first step, and second step, angiotensin neprilysin inhibitor, and mineralocorticoid should be in the last step, should be started in patient with dilated cardiomyopathy, not in all patients with heart failure due to ejection fraction. It is a one line of treatment, but in another directed categorization, they have directed the simultaneous rapid sequence of initiation and titration of guideline-directed medication should be done. In this scenario, they have used all drugs, all 4 fundamental drugs in the first sequence, but gradually the inhibitor started to increase the doses. Initially with beta blocker, then with the other drugs. So it is a one thought of theory. But according to Sharma et al. And Journal of Medical Medicine, the 4 therapies on board in 4 weeks. They want to start 4 therapies in 4 weeks. So apart from using the guideline-directed medication, we have to think about the adverse interstitial potential side effects of directed drugs like hypertension, declining GFR, hyperkalemia, and treat accordingly. So remission or resolution of heart failure is directed by normalization of the symptoms and normalization of NT-proBNP. TRADE heart failure trial, the withdrawal of pharmacological treatment of heart failure patients require dilated cardiomyopathy has shown that withdrawal of therapy should not be usually advised in patients. And TRADE heart failure study was a big study. In study, they have seen the patients with dilated cardiomyopathy and treated them accordingly. And according to their findings, relapse of dilated cardiomyopathy occurred within 6 months after stopping the guideline-directed drug. So drug shouldn't be stopped. At the end, I would like to say the remission have been achieved. It is unclear the treatments and need to continue it for long term. For long-term treatment continuation, we should have to think about the intrinsic myocardial susceptibility, acquired triggers, and myocardial workload. And last but not the least, for treatment of heart failure with reduced ejection fraction, I would like to say that we should treat all patients with guideline-directed medications and other adjunct medication. And one thing we have to take in mind, the improvement in function represent remission rather than permanent recovery of many patients with dilated cardiomyopathy with reduced ejection fraction. Thank you very much.
Excellent presentation. So all 4 speakers have given their speech. So we are at the end of our session. So I'd like to request the chairpersons to make a few comments regarding the presentations. So I'd like to ask Professor Sohail Mohammad Arafat sir to make a few comments.
Thank you very much. First of all, I thank IPT organizers to select me as one of these chairpersons. This session is for heart failure. Heart failure is a cancerous disease. Amra cancer shunle longevity, treatment cost, and effectiveness, sab kichu mile chinta korle je a heart failure take khub it is a dangerous disease. And amader speaker they have mentioned the methods of treatment and the prognosis very nicely. And I thank the speakers also for their timely accepting the first one who has crossed the much limit of time. And it is a heart failure treatment is costly, and that is one of the most important factor in our country. And the R&D, the device method, electrical device method of treatment of heart failure, these are all costly. Most of our patients, they cannot afford. And I thank you for everybody for selecting me, and thank you very much.